Welcome to Pharmacy View Podcast, where we provide regular interviews with pharmacists and key people within Australian pharmacy and the associated global industry. In this stream of podcast episodes titled RX to Riches, we delve into the evolving global pharmacy landscape, exploring the challenges and opportunities, and examining the current state of retail pharmacy across the globe. With each guest, we discuss the hurdles they face and the potential growth areas that may shape a brighter future for your pharmacy or industry-related business. I'm your host, Michael Alexander, pharmacist, digital health enthusiast, and co-founder of Audirie, an AI-powered communication intelligence platform serving the healthcare industry across the globe. My guest today is proudly brought to you by Shopfront Solutions for all your shelf and digital marketing needs, part of the Arion Technologies
Well,
group.
I don't even know that other countries actually develop a formulary, but, we went from having open access to drugs to narrowing that access, which is what a formulary is, right? So it's specific drugs that you can get through that PBM. And they can also tier them. And that's where the rebates come in. The assumption is that the preferred drug is going to deliver better outcomes and that you're going to get it at a reduced price.
But is that true?
Not necessarily.
Well, why wouldn't it be true? I mean, why wouldn't you just put the most efficacious drug and have that one be the only one?
Today on RX to Riches, we're delighted to welcome Dr. Drew Oliveira and Denise Giambalvo. With over 17 years of experience in healthcare and insurance, Dr. Oliveira is a seasoned physician leader. He's held senior positions at health insurers Cambia Health Solutions and Aetna, focusing on areas such as utilization management and network contracting. Alongside his corporate roles, Dr. Oliveira has been a clinical associate professor at the University of Washington for over 3 decades. Currently, he's serving as the executive director of the Washington Health Alliance, where he's dedicated to improving healthcare quality and affordability. Denise is a strategic healthcare leader whose accomplishments include forging partnerships for PBMs, developing cutting-edge software for healthcare programs, and spearheading initiatives to manage specialty drug costs. With decades of experience in the healthcare space, Denise has held key roles such as vice president at the Midwest Business Group on Health and executive director at Employers Health Coalition. In her current role as director of member engagement and business strategy at the Washington Health Alliance, Denise continues to drive strategic planning and cultivate key relationships. Welcome to you both. Well, thank you again for joining me today. I want to start out by just exploring a little bit about your backgrounds and what you've done so far in the industry and what's brought you here today. So, Denise, please, I'll start with you.
Sure, thank you. Happy to be here with all of you today. Denise Giambalvo, and I actually worked for over 2 decades in retail before I left that industry and found my way into this employer-led coalition for improving the quality of care for employees, while also focusing on getting total cost of care down. There's coalitions like ours across our country, and this is my 3rd one now that I'm working for, and really enjoying being in Seattle doing this.
And I'm Drew Oliveira. My background's a little different. I'm a family physician by training, practiced here in the Seattle area at both a community health center and then an academic medical practice, doing medical education for about 18 years, affiliated with the University of Washington. I then transitioned and worked on the insurance industry side for a similar number of years, sort of kind of getting into the weeds in terms of what insurance companies in the U.S. do, and then taking a little broader view on the employer side, how it and we can talk about that a little bit about how employers in this country have the ability to essentially create their own health plans, if you will. They're called self-insured because they get to choose what they cover, how they do it, what the benefits look like, et cetera. And then I, was lucky enough to be able to come and work with Denise and our colleagues here at the Washington Health Alliance, where our real focus is how do we improve quality? How do we improve access? How do we improve affordability? And how do we do it in a way that starts removing health disparities with a real focus on the employer community who is usually paying for this bill.
Okay, so the reason I wanted to have this conversation was to educate both our overseas listeners and as well as our local listeners about the healthcare system. There's a lot of confusion around how does the healthcare system work and what kind of incentives are there in the healthcare system, and is it fundamentally broken? So there is a lot of confusion, and frankly, when I talk to some of our overseas listeners, they're just bewildered about how the system works. So that's why I've brought two experts here to dive into the system itself and really educate our listeners. And I'll probably learn a couple of things from you along the way as well. So that is the overarching reason why we're here today. But we're also going to dive into other topics, that you're interested in, and we'll follow the conversation wherever it goes. But I did want to start with you, Dr. Oliveira, and start at the very beginning with the historical evolution of our healthcare system. So how did we get here? And what factors have shaped our current healthcare landscape, in particular with accessibility and affordability for patient care?
Sure, Mike. I think, whatever system you have is designed to do exactly what it's designed to do. It evolves over time. And the US system is similar to that. You can go way back 150 years and it was very apothecary driven, right? And because that was, the only provider, if you will, that had anything that was worthwhile. And over time, we started seeing an evolution of care. And even in the US, in around 1920, they even proposed having a national healthcare plan. And it got stopped by mostly the Pharmacy Association, and there wasn't really, enough of an incentive for that back then because there wasn't a lot of care that was being delivered in facilities. It was more care at home, and that is pretty reasonable. In the 1930s was the first time we started saying anything that looked like an insurance program in the U.S. And it came out of the Houston School District, and the teachers there wanted care was being delivered more and more often in hospitals, and people were delivering babies. So they wanted their care to be in the hospital, and they wanted to prepay for that care. That care came at a price of $6 a year. And so people would prepay the Baylor hospital system for maternity care. And that was very popular among the teachers union, and they thought that was great. And Baylor said, wow, we get paid whether they get pregnant or not. This is like a good thing. And so, but, it was in the middle of the Depression, funds were tight, but that was kind of where they went. Fast forward a couple more years, you had World War II. And World War II, was a financial strain on almost every, country that fought in that war. Same thing in the United States. And one of the things that the U.S. did to try to pull out of that financial stress was to put a wage freeze, or they call it a wage stabilization act. And they didn't allow employers to increase wages. And but they did allow them to add other components. And so what you started seeing in the workforce is when you couldn't give a wage increase, you gave something else. And so what else could that be? Pension plans started growing rapidly. But also the concept of health insurance was one that had gone from that Baylor program to now more hospitals saying, hey, we'll provide hospital care. Physician groups came in to say, hey, we can provide physician care in a prepayment methodology. Those two were the forefront of the Blues plans, which you might have heard of in the U.S., the Blue Cross plan, which are hospitals, the Blue Shield plan, which were physicians, and they soon coalesced into plans around the country. And by the end of the 1950s, what you ended up with was the majority of employees having one of those types of insurance products, because that's what an employer could give to incent you to stay with that employer. And then wages started to go up as well. In 1958, 75% of the U.S. was then covered under one of these insurance plans, almost entirely through their employers. The other 25% missing fell into a couple of three categories. If you weren't employed, you would have to buy insurance on your own. So if you could afford it, that would be something you could buy. If you were poor, you were not insured. And if you were elderly, you were not insured. And so that then moved, fast forward a couple more years, and they said, well, we can't have that. We need to take care of the poor, and we need to take care of the elderly. We've started two programs in the U.S., the Medicare plan, which was for the elderly and disabled, and then the Medicaid plan, which was for the poor. That was pretty good, but it still left a number of people without insurance coverage. They could pay out of pocket or hope for charity care, but it wasn't universal healthcare coverage like you would normally see in other countries. It was funded by employers and now the government picking up the tabs for the poor and the elderly. It left a number, a fairly large percent of the population uninsured. And that number stayed fairly consistent over decades. Somewhere in the 12 to 18% range would remain uninsured young adults. So first, getting out, on their own when they're 20 or 21, they typically didn't have any healthcare coverage. The working poor may not have healthcare coverage, and then some people just didn't apply, and so you ended up with not a fairly rational system, but you ended up with a system nonetheless. All of this was paid, kind of as you go, and it was paid in a what we call fee for service basis. So private hospitals, private physician groups, private providers of care would then provide the service. They bill the insurance company. The insurance company would then pay, and it was pretty standard for years on end until increasing amounts of care became increasingly expensive, and then they wanted to start reeling some of that in, and that was really kind of the 80s and 90s when you started seeing some form of cost containment start to happen in the healthcare system.
All right. Well, it's very, I think the idea of employer-sponsored insurance is a very foreign concept for some people. I want to ask you, why do we end up getting stuck with that type of insurance? Why could we never shift? And, this comes up, every couple of years, Medicare for all, and, the ability to expand Medicare and Medicaid to cover everybody. Why is it so hard to shift from an employer-sponsored insurance model to a Medicare for all model?
Yeah, I mentioned 1920. There was a push for a national program that occurred again in the late 50s as well, where there was a push for we should just do a national insurance product or a national, nationalization of the healthcare industry. And there was a lot of pushback because who was making money at that time? It was the providers of care, so the physician organizations, Blue Shield plans, et cetera, and the hospitals. They were doing really well. They didn't want to change that. Likewise, employers and employees, especially the unions, liked what they had. They knew their employees were getting coverage that was a benefit. You're not going to take away my benefit, and so they perpetuated that because they said, "Look, it's working. It's designed to work the way it's working. It's working fine, and we're good with that." And so that got shot down as well. And when it got shot down, that's when you started seeing the U.S. come back with a Medicare and a Medicaid plan to cover those people that were uninsured. When we haven't really seen it, we've seen talk about trying to get to a variety of different solutions in the U.S. from, you mentioned Medicare for all, which is, means a lot of different things to different people. Is it one insurance? Is it an insurance run by a bunch of insurance plans? Is it one pricing model? Is it universal coverage? All those are yes and no answers. So depending on who you ask, and because we've been in sort of a fee for a service, you started seeing a lot of entities figure out, well, where do I get the highest fees? What services can I do? And you see the insurance plans trying to chase the utilization game in terms of, oh, I'm seeing something spike over here. Let me try to manage that. And you also see a mismatch in terms of what's needed from a population-based standpoint in terms of what's the right physician workforce, what's the right number of hospitals. Other countries sort of manage that, much tighter. You got a certain population, you need X number of beds, you need X number of docs, you need X number of primary care providers. And we didn't take that approach. It was much more of a capitalism guy. We got capitalized process, if you will. There wasn't funding to fund one or the other. And there was, frankly, some money to be made by, especially on the academic medical centers who were trying to train providers. They actually got paid a little bit more from the Medicare plan to train specialists than they did to train primary care. And in a fee-for-service world, specialty care derived more revenue than primary care, and thus fueled that engine, if you will, of increasing specialization in the process. As a result, the U.S. has, at best, 25% of the physicians are in a primary care specialty, and 75% are a subspecialty or a specialty. And that results, statistically in, lower screening rates, lower closure of care gaps, higher utilization, and higher misuse or overuse of services. And we see that in a variety of different areas. The areas in the U.S. that have the best quality and cost results have a higher percentage of primary care and a lower percentage of specialists. And those parts of the country look the best from a quality and a cost perspective.
And I would just add, culturally, it's been very challenging for us to move to a single payer or multi-payer that's under a single umbrella, because in the United States, we like to have choices. And we won't get into the irony of that with recent legislation that takes women's choice away. But so just our our population in general gets worried when the government starts talking about taking over healthcare and getting too involved in our lives and potentially taking choice away from us.
Well, it's a very complex problem, obviously, and there are a lot of moving cogs, and one cog in particular that we haven't touched on yet in this whole landscape are pharmacy benefit managers, or PBMs for short. So, for our listeners who might be unfamiliar, Denise, could you provide an overview of what a PBM actually is, what it does, and what their role is within our healthcare ecosystem?
Maybe why do you talk about that, Denise? And you know what? Because I think it's like, then why would you even have someone managing pharmacy? How does that work? And how like, why would an employer even care?
Why would they care? A pharmacy benefit manager, there's a lot they do actually. Whether or not it's all needed is a whole other story. But the primary purpose for them and how they came about was for claims adjudication. And so that's how they came into existence. It's a primary function of theirs today. But the other things that they do is they contract for pharmacy networks. So they put together networks for people to purchase within with certain price guarantees. They handle formularies, so they develop formularies. Within that, they'll run prior authorizations. They will make recommendations for benefit design. They have utilization management. They have pharmacies of their own, so they'll have a mail order pharmacy. They'll have a specialty pharmacy, right, where they're only dispensing specialty drugs, and so then within that, they're offering special services for those complicated patients. They negotiate rebates and other administrative fees that tie into the formulary development that they do. So there are a lot of different functions within that. Again, primary role is really for them to do claims adjudication. Happy to dig into deeper to any one of those if you'd like.
So it sounds like they do some good things, right? So because we have a fee for service health system, so they're paying the claims. So if someone gets their drugs at the pharmacy, they pay the claims. They pay at a rate that's a negotiated rate that's maybe some savings for that patient. So they're not paying a full
Potentially.
They're paying the pharmacist who's dispensing. They're making sure that there are enough pharmacies that people can go to get their medications. So sounds like good stuff. And then you said they develop a formulary, which might be different than the way they do it in other countries, because we develop our formularies a little differently here.
Well, I don't even know that other countries actually develop a formulary, but we went from having open access to drugs to narrowing that access, which is what a formulary is, right? So it's specific drugs that you can get through that PBM. And they can also tier them. And that's where the rebates come in. The assumption is that the preferred drug is going to deliver better outcomes and that you're going to get it at a reduced price.
But is that true?
Not necessarily.
Well, why wouldn't it be true? I mean, why wouldn't you just put the most efficacious drug and have that one be the only one?
So on the back end, they're negotiating with the pharmaceutical manufacturers for placement on their formulary. So, pharma manufacturer is paying for that preferred placement. And that comes in the form of rebates and other administrative fees. And so that actually boosts the cost of our drugs from the front end.
Can you explain what a rebate is? Because I'm guessing that doesn't occur.
In other countries,
I'm just guessing.
thinking?
I don't know, maybe,
Not?
but
I don't know.
maybe
I
at
think-
least how we think of a rebate.
Yeah. So it's
Is it something that me as a patient I get because it's on the formulary and I use that drug so I get money back?
not typically.
Oh,
So, sometimes at the point of sale that could happen, but it's they're actually guaranteeing a certain volume in sales. We'll put your drug in as a preferred, right? So we're going to put incentives in place for this drug to get dispensed over another. And we are going to guarantee, based on the membership that we're serving, that X number of your drug will be sold annually. Actually, they do it quarterly. And quarterly and annually. Yeah. Anyway. And so based on that guarantee, the pharmaceutical manufacturer agrees to give them a certain amount of money per dispensing.
so
So-
normally, let's say, the drug is $10 and
We're
I
gonna
put it on the formulary. So
we're gonna add 40% probably minimum and up to 75%. So it's let's say it's $14 instead of 10.
well, wait a second. I thought you said I got money back.
Well, the patient doesn't
I
get
don't
money
the
back.
patient does.
No,
Oh.
the patient doesn't get money back. No.
So, wait, I thought the drug was $10 and now you say it's $14.
Right, because we're gonna boost the price with the amount of rebate.
And then you're going to give not the patient back the difference.
No,
Yeah.
no.
Who gets the difference?
Well, your employer might get some of it.
Yeah.
For them to apply as they want. Right? So they
Right.
typically will apply it to their total cost of care so that it brings premiums share down for each employee. Which is also another complicating topic.
So
Right?
so it costs now $14, but I'm going to give all of the difference back to the employer.
No,
No.
because as the PBM, you negotiated that, right? So you should receive something
Because I'm the PBM.
because you're the PBM and you negotiated that special deal. So you should receive some of that money for your time that you spent doing that, right?
So instead of getting the $4 back to get down to 10, I get to keep 2 and I give 2 to the employer. Is that how that works?
Hard to say.
Hard to say.
Hard to say because those contracts are not visible to the employer. So they have no way of knowing what the PBM negotiated with the pharma manufacturer. So
It's getting complicated.
we only know what the PBM tells us.
Sure.
Yeah, we don't have a right to see that information.
So what you're saying is to the employer, having the rebate may have actually increased the cost of the medication, not decreased it, at least from their perspective. And the pharmacy benefit manager we already paid to pay the claims and have networks. We already paid them to do that.
Right.
It's now making money off of us because we had to pay more for that drug in terms of getting on the formulary with a rebate.
Right. But, you know, after you close out that quarter, right? Maybe another 2 months later, you get a check for all in rebate money for all the drugs. Well, not all the drugs, but for those that have rebates on them, right? The employer gets that check. And so you're like, that's a nice sum of money, right? When you're looking at it in total. Anyway, CFO says, oh, that was a nice little charge back that we got.
But it doesn't seem to help to lower the cost and the payment for the patient.
Oh, we're supposed to do this for the patient.
And you also said that they're paying to get their drug put on the formulary, but not necessarily because it's the best drug for that condition. It might be equal to another drug.
It might be lesser than.
It's like, in the past, we had all the PPIs or, clinical evidence was they all work exactly the same way. And so just pick one.
Right.
So this could be the same thing, but now I have to pay more to maybe get the rebate back for the same. Okay, now I'm confused. So how come we don't just put the best drugs on a formulary based on the clinical evidence in the U.S.?
This is the end of part 1 of our 2-part discussion. Look out for part 2, dropping next week. See you then. Thanks for joining us today on the Pharmacy View podcast. And don't forget to like, share, and leave a comment if you found this episode of value or have any feedback. Podcast episodes are promoted through social media, LinkedIn, YouTube, and major podcast mediums. And each episode can be found on the Pharmacy View webpage with links to guest contact and business details. If you're a pharmacist or industry support supplier and would like to join us on an episode, send us a message through LinkedIn or complete the inquiry form on the Pharmacy View webpage. I'm your host, Michael Alexander, pharmacist and co-founder of the communication intelligence platform Audirie. On behalf of Shopfront Solutions and Arion Technologies, thanks again for joining us today on the Pharmacy View podcast.